Psychotropic prescribing in older adults. Safe. Evidence-based strategies for geriatric and polypharmacy care. Today, we will explore how to prescribe psychotropic medication safely for our older patients, especially those juggling multiple drugs. Older adults are the fastest growing segment of the mental health workforce. 20% of adults 65 years and above experience depression, anxiety, insomnia, or dementia-related behavioral symptoms. Yet they also bear the highest burden of polypharmacy, with an average of 9 prescribed medications per person. This combination raises the stakes for adverse drug events, falls, cognitive decline, and hospitalizations. Our goal is to translate the latest evidence into 3 practical pillars: assessment, prescribing, and deprescribing.
Comprehensive assessment, screening, and baseline. Use validated tools like the PHQ-9 for depression, GOD-7 for anxiety, and the Insomnia Severity Index. Document cognition such as the mini-cog or the MoCA, and functional status for ADLs and IADLs. Medication reconciliation. List every prescription, OTC, supplement, and herbal product. Identify high-risk psychotropics like first-generation antipsychotics, tricyclic antidepressants, and benzodiazepines that are Beer's criteria's avoid medications in adults 65 and older. Risk stratification. Evaluate renal hepatic function, QT interval, fall risk, and comorbidities such as Parkinson's or COPD. Apply the stop-start algorithm. Stop flags potentially inappropriate psychotropics. Start reminds us of undertreated conditions like untreated major depression.
Prescribing principles. Start low, go slow. Typical geriatric starting doses are 1/2 to 1/4 of adult doses. Once daily dosing reduces pill burden and improves adherence. Avoid anticholinergic load. Use the anticholinergic cognitive burden or the ACB scale. Aim for ACB of 2 or lower. Check drug-drug interactions via a clinical decision support system. Be vigilant about CYP 450 inhibitors like fluoxetine plus carbamazepine. Educate caregivers on expected onset and side effect monitoring. Expected onset is often 2 to 4 weeks for antidepressants, and side effects like sedation and dizziness for most medications.
This is a table of common psychotropic prescribed to those aged 65 and above. Major depression, first-line agent is sertraline. Recommend start at 25 milligrams per day, increase to about 50 milligrams daily after 2 weeks. Monitor for hyponatremia and GI bleed if taking NSAIDs. For generalized anxiety disorder, first-line agent is escitalopram. Recommend start at 5 milligrams daily, max 10 milligrams daily. Avoid concomitant serotonergic meds. For insomnia, first-line agent is low-dose trazodone 50 milligrams at bedtime or ramelteon. Recommend start trazodone at 25 milligrams or ramelteon 8 milligrams. No benzodiazepines, watch for orthostasis. For behavioral symptoms of dementia, first line is non-pharmacologic. If needed, low-dose risperidone at 0.5 milligrams or lower, daily. Recommend start 0.25 milligrams daily and limit to 12 weeks or shorter. Check baseline and periodic drug-induced movement disorders, metabolic panel, and fall assessment. For psychotic disorders, first-line agent is second-generation antipsychotics. Recommend start at very low doses and titrate slowly. Watch for QTc prolongation, weight gain, diabetes.
Deprescribing and ongoing monitoring. Scheduled review every 90 days for any psychotropic sooner if adverse events occur. Deprescribing algorithm, based on the American Geriatric Society guideline. Assess necessity. Is the indication still present? Taper gradually. Reduce dose by 10 to 25% every 2 to 4 weeks. For benzodiazepines, use a dose reduction schedule. Monitor withdrawal, track anxiety, insomnia, or rebound depression using the same screening tools. Document, record rationale, taper plan, and patient caregiver agreement. Fall prevention. Conduct gait and balance testing after any dose change. Consider physical therapy referral. Laboratory surveillance. Regular laboratory surveillance includes checking serum sodium for SSRIs, glucose and HbA1c for atypical antipsychotics, and lipid profiles every 3 to 6 months.
Key takeaways: assess comprehensively. Screen, reconcile, risk stratify. Prescribe using geriatric-friendly agents, low starting doses, and vigilant interaction checks. Deprescribe proactively. Most older adults benefit from periodic dose reductions or discontinuation. By embedding these steps into every clinic visit, we can reduce adverse drug events, preserve cognition, and improve quality of life for our older patients.